We are going live in 5, 4, 3, 2, 1. We are live now.
Okay, good evening, everybody, and welcome again to today's program brought to you by the Orthopaedic Research and Education Foundation. Today's webinar is going to be a talk by Dr. Dhiren Ganjwala, who all of you know, who's from Ahmedabad, and he's going to talk about decision making in cerebral palsy. So this is going to be, again, a very instructive and sort of valuable talk for all of you, I hope. And I think you all know by now that Dhiren has a way of simplifying things and getting his ideas across in a very sort of what's the word that I'm looking for? Instructive and with pictures which really explain things to you. So as people say that pictures are worth 1,000 words. So I think over to you, Dhiren, to give us your talk today.
Yeah, thank you, Dr. John, for introducing the subject, or like my style of sharing the knowledge. Today we are going to discuss about decision making in cerebral palsy. And at this stage, I would like to mention specifically about one of my good friend, Dr. Anil Agrawal from Chacha Nehru Bal Chikitsalaya in New Delhi. Many times, like, he share his videos, his patients' videos with me with the clinical examination. And then he asked me about which type of or what surgery needs to be done. So after, like, I gave him answer 2 or 3 times, then he said that, can you tell me about how do you come to this decision? And actually that really made me to think about what is going in my mind. And today I'm going to discuss that, what is going in my mind. To those who are listening this lecture for the first time, I would just like to say that few weeks back, exactly 4 weeks back, I took a lecture on examination of a child with cerebral palsy. And if you have not attended that lecture, then here is a link. If you forget about it, just write down Ortho TV, Oref, and examination of a child with cerebral palsy, and you will come to this link and watch this presentation. So that will give you the basic idea about examination. I'm going to one step further, and we are going to focus on the decision making in this session. So first of all, what is the role of orthopedic surgeons for a child with cerebral palsy? We have few important duties to play. And the first is, we are, or in most of the cases, we can improve gait of child with cerebral palsy. Not all children, but most of them. In addition to that, we can carry out treatment, not surgical treatment, but before that we can carry out non-operative treatment for prevention of the contracture. So that's the second role of orthopedic surgeon. In addition to that, some of the patients have pain, and we can prevent or alleviate that pain. That's the third role of orthopedic surgeon. And prevention or correction of the scoliosis, and similarly the hip dysplasia. These are the important duties of orthopedic surgeon for a child with cerebral palsy. Not all children with cerebral palsy, they need all the 5. They may need only 1 or 2. But this is what the overall role of orthopedic surgeons. Today we are going to focus on a very important role, improving gait of a child with cerebral palsy. When we say we want to improve gait, or our aim is improving gait, there are 2 important tasks which we are doing. The first is, we are improving the appearance of gait. We know that these children, they are walking differently than the normal child or adult. And our role is to make the gait as near as possible. So there is an index called gait deviation, how it deviates from the other people. In cerebral palsy, we want to make this gait as near as possible. But that's what parents look at. What is more important, which they don't know, is improving the gait efficiency. And why this is important? When you improve the gait efficiency, the energy requirement or the energy consumption for walking is reduced. And because of that, child can walk longer distance with less tiresome or less fatigue. So this is, I think, more important as an orthopedic surgeon, that we want to improve the efficiency of gait. While parents, they look for appearance part. When the patient comes to us, we have a various questions related to gait improving surgery. GIS is gait improving surgery. When to operate, where to operate, means whether to operate at the hip flexors, hip adductors, knee flexors, knee extensors, which type of surgery. And the most important thing is when not to operate. I am not making a big list, because I know that if I put a big list, then you will lose your interest in cerebral palsy, because most of the person who is not well trained for cerebral palsy surgery, they are puzzled or lost when they listen to the lecture. So I will try to keep it as simple as possible so that you really don't get lost into too much detail. So now let's come to the most important thing, decision making for gait improving surgery. First of all, I am going to give you overview what actually we need to do. And after that, we will have one case example by which I will try to exactly replicate the process which I am describing in the overview. So first of all, I will give you the bird eye view of the process, and then we will apply that process for a one particular case. So first thing which we need to do is we need to find out gait abnormalities. What is abnormal in the gait? That's the first thing we need to do. How to do that, we will see in a minute. So for that, we need to record the video. Now we have almost every good mobile can record the video. So if we record the video from the right and the left side, we need to record the video from both the sides. So either patient is going from one direction, and when it's returning, when the patient is returning, in that case, the other side is also recorded. So we need both the sides to be recorded. In addition to that, we also need a recording from front and back. Only side is not adequate, side view is not adequate. We need a front and back video also. Once we have that video, you either can take it to the computer or you can play in a slow motion in the mobile also. So you can see that video with reducing the speed so that you can analyze the gait better. While walking, so many movements are taking place in a fraction of a second. So it's sometimes difficult for us to identify the gait abnormality. So slow motion is a wonderful tool for finding out the gait abnormality. And the last thing is, if you really want to analyze a minute detail, then ability to watch frame by frame is a very good or important tool for that. So you need a software. Usually the if you are using Windows, then Windows Movie Maker is a very good tool in which you can see the videos in a frame by frame mode. Even other video players also have that feature available, but you need to take both forward and backward facility for the frame by frame mode. So VLC player is another popular player, but the problem with VLC player is like you can go in a forward direction, but in a frame by frame mode, you cannot go reverse. So that's the limitation. So usually I use Windows Media Player or Windows Movie Maker. What are the common gait abnormalities in cerebral palsy? If you make a list, there are only few gait abnormalities which are seen in cerebral palsy. This is something like a fracture pattern. If we take a example of a tibial plafond fracture, we know that there are only few types of fractures which we come across. So similarly, we come across very few gait abnormalities in cerebral palsy. To describe the gait abnormalities, we are first describing the sagittal plane, means when we are looking from the side, what we see. Usually we see that ankle is in plantar flexion, which we call it equidus. In adolescent cerebral palsy patients, sometimes we see excessive dorsiflexion at the ankle joint, which is called a part of the gait abnormality is called crouch gait. So either ankle plantar flexion, that's equinus, or a dorsiflexion are the common gait abnormalities. Then comes the knee, and at knee, most of the children, they have knee flexion problem. Some of them have a stiff knee gait. Stiff knee gait is a gait pattern during swing phase. They don't have a normal knee flexion. Normal knee flexes to 60 degree, but these children, they don't have that much flexion, and that is called a stiff knee gait. Please remember that stiff knee gait is a swing phase abnormality. Sometimes we have a knee recurvatum or knee hyperextension also. And similarly, hip flexion is another component. So at ankle, we see plantar flexion or dorsiflexion. At knee, we see in most of the children knee flexion gait. Some of them have a stiff knee gait. Very small number of children have knee recurvatum. And at hip, the hip flexion is common. So that's about the side view. Now we come to the front and the back plane, which is called the coronal plane. And in that, we see some abnormality like there is a valgus foot, or occasionally there is a varus foot. Equinus deformity is occasionally combined with varus, and that's called equinovarus foot. Most of the children, diplegic cerebral palsy children, have a valgus foot deformity. In addition to that, they have a hip adduction gait. When it is severe, the two thighs crosses each other and they make a cross, and that is called scissoring. Occasionally, they have a waddling gait in which the child is lurching, and every time the child is putting weight on one limb, the upper body also lurch on that side. So waddling gait or Trendelenburg gait are the common gait abnormality. Coming to the transverse plane. Transverse plane abnormality are the recent addition to the list. When I say recent, means in last 15-20 years, we have understood that many children with cerebral palsy has a transverse plane problem. And that is the pelvis is retracted, means it's rotated backwards. That is one abnormality. In some patients, the knee is pointing inwards. So if you look at the patella is not in the front, but it's pointing in. Or occasionally they are pointing out. And similarly, there is a foot, it is pointing in, which is called in-toeing, or rarely it's out-toeing. So these are the transverse plane abnormalities. So first we saw about the gait abnormalities. Now the next important thing is like you need to think about the reasons for these abnormalities. Most of the time we know that this particular abnormality is because of X, Y, Z reasons. And that is mostly known to the experts who are doing it. If you are not familiar, just try to make a list of the abnormality which I mentioned, and just ask your colleague, the senior colleague who has experience, that what could be the reasons for each abnormality. So finding out gait abnormality is basically the visual thing. The second thing is mainly the mental thinking. So what are the broad categories? When it comes to abnormality, either this abnormal gait can be because of a neurological problem. We know that cerebral palsy is upper motor neuron problem, and the signals from the brain are not reaching properly to the muscles, and that's the reason for abnormal walking. And in addition to that, there are few musculoskeletal problems. If you are not clear about that, I request you to look at my last lecture before a month. And in that, I described that there are 4 types of musculoskeletal abnormality. The one is some muscles are short or spastic. Some muscles are long or weak. There may be some joint deformity, or there may be a bone twisting. So these are the musculoskeletal problems. And as an orthopedic surgeon, it's our duty to identify these musculoskeletal problems and tackle them. hardly at this stage we have much to offer to the neurological problems. So once you have identified the possibility that this could be the reasons, now we use the information which we have gathered from clinical examination and imaging. So here the process is slightly different. We don't go for the clinical examination first. We go for the gait abnormality first, and then we try to find out the reasons, and then we use clinical examination. The important point is that you have make a list of gait abnormalities and you have a clinical examination findings. If these two, gait abnormality and the clinical examination findings, are matching, in that case, yes, you are on a correct path. However, occasionally we come across a situation where gait abnormalities seen on the video and the clinical examination are not matching. In such situation, we have to be careful, and it's very important that we pause and review everything again. In some of the cases, we can use examination under anesthesia, because when we look at the child under anesthesia, the spasticity is taken care of or is removed, and what we are looking is only the muscle contraction. So that will help us to remove the spasticity problem from the equation, and whatever you are examining is only the muscle contraction. Or we can use a neuromuscular block like a botulinum injection, or in the past we used to give a xylocaine injection in the muscle to relax the muscle. Or the third is we can give plasters at knee joint or at the ankle joint, and we can understand the effect of adjacent, the effect of one joint on the adjacent joint. As for example, many of the cerebral palsy patient, when they have a equinus at the ankle, they have a recurvatum at the knee joint. So this recurvatum is secondary to the equinus problem. So if you give a plaster in a neutral position and ask the child to walk, then you have taken out the effect of equinus by plaster, and then you can see what happens to the knee joint. So occasionally we need to use plaster cast also. But this is mainly when your clinical examination and the gait abnormalities which you have identified on video, when they are not matching with each other. So we saw 3 points: finding out the gait abnormality, reasons for abnormality, and then comes the clinical examination. The fourth is, based on this, we prepare a surgical prescription. Means we need to do this surgery. So we make a list of surgeries which we need to carry out. Now, at this point, I would like to mention very important thing, that there is a lot of individual opinion or differences in the prescription which we give. I consider this as a situation that if someone has a upper respiratory tract infection, if he goes to one physician, he may give a one particular antibiotic. If the same patient with the same clinical examination goes, doctor may use a completely different set of antibiotics. Now, it's not that the first doctor is wrong and the second doctor is right, or the other way around. Both are right, because there is an individual difference in the management. Similarly, when there is a diaphyseal fracture of tibia, some doctors prefer plating, while some prefer nailing. And even some people, they just say that the casting is also equally effective. So in that, none of them is wrong, because we need to understand that individual variations are always there. Then comes the important point, that based on your opinion, your experience, you decide and operate. So operation is a small part, but before that, the first to fourth step are very important. Once we operate, after a few months, we remove the plaster and we ask the child to undergo physiotherapy. But then at 3 months, 6 months, 9 months, 12 months, we need to reevaluate the child. We need to take a video if required and to see what went well of the prescription which we have given, which surgeries are able to give result, and what did not go well. So this is basically we are building the experience. It's very rightly said that good decision comes with experience. But the question is how we get experience. The experience comes by learning from our own mistakes. So this is very important, that whenever we carry out a surgery, if it does not work, then we need to understand that why or what went wrong and why we did not achieve the desired result or the expected outcome. At this stage, I also like to say very openly that I have also made mistakes. Some of my patients have not improved as I have expected, or even the parents have expected. So this is very important, that we need to evaluate our own result, and that gives us a more clarity about what is working and what is not working. So that was about the overview of the decision-making process. Now we come to a one case example. And what I want you to do is like just try to look at this video and tell us what is actually the problem. So step one, analyze the video. I am removing the part of taking the video because I am already showing you the video. But the important thing is to analyze the video. I am not going to play this video in a slow motion. So I am playing at a normal speed and try to identify what are the gait abnormalities. This is 10-year-old child who has not been operated anytime in the past, only undergoing physiotherapy. His MRI clearly shows that there is a bilateral periventricular affection, leukomalacia. For this first case, I am not showing you the front and the back view because I want to keep it simple. So in this, there are few gait abnormalities which we are seeing. The first is there is a knee flexion. There is a ankle plantar flexion. These two are very obvious. The third, experienced person can see that there is a waddling. The waddling can best be seen in the front or the back videos. But even with this, you are able to see it very clearly. So what I'm doing is like I'm going one slide back, and I also want you to see again and understand that there is knee flexion, ankle plantar flexion, and waddling gait in this video. So three things: knee flexion, ankle plantar flexion, and look at every time the child is walking, the child is moving the upper body, and that's called the waddling gait. Now coming to the next step, that is about what can be the reasons for these abnormalities. We are trying to understand that. So now we have three gait abnormalities. We will see one by one what could be the possibilities. So the knee flexion, the first very apparent problem is a knee flexion. And in most of the cerebral palsy children, this knee flexion can be because of the short hamstrings. I've shown these animations in the previous lecture also. I am using it again so that it becomes very clear. So we are looking from side, and we are looking at the right side lower limb, which is in the swing phase. So what happens in the swing phase? Initially, there is a knee flexion, and later on, there is an extension of the knee. Now, at the terminal swing, if you look at the hip is flexed and the knee is completely extended. If you understand that hamstring is behind the thigh, it is behind the hip joint, behind the knee joint. So at this particular terminal swing, the hamstring is maximally stretched, or it has to stretch fully. The first hamstring shortening, or the earliest or the beginning of the hamstring shortening, will affect these phases. And what will happen? Let's see that. When the hamstrings are short, look at this, what happens. When hip flexes, the knee cannot extend fully, because to knee to extend, we need a full length of hamstring, which is not available. And that's why knee remain in flexion like this. So knee flexion is seen first at the terminal swing, and then it's because of the short hamstrings. Later on, it's seen in the stance phase also. The second reason for the knee flexion can be because of long quadricep muscles. We saw that in the last lecture also. Again, I would like to explain. Let's see a child who is in an examination table. He is lying down, the hips are extended, the knees are bent to 90 degrees. Now we ask the child to carry out the knee extension. Now we are asking the child to carry out, so that's active extension. Let's say that child is able to carry out extension up to this much. Once we have reached this level, we carry out a passive extension. So now examiner carry out passive extension. And let's see that this much passive extension is possible. Remember, this was the active, and now this is a passive. So the difference between passive and active is called extension lag. We all know that many of the patients who have undergone surgeries around knee joint, they have extension lag. There is no flexion deformity, but patient is not able to carry out active knee extension. So that's called extension lag. Now look at this patient. When this patient is made upright like this, the patient cannot extend the knee fully, and that's why knee remain in flexion. So the second reason for knee flexion could be long quadriceps. The third is the knee fixed flexion deformity. The contracture at the knee can cause knee flexion in the stance phase. And very occasionally, there is a weakness in the calf that also leads to knee flexion. I'm not describing that in detail because that concept is a bit difficult to understand. So just remember that the weak calf can also cause knee flexion. So that was about the first deformity, that how we can identify or what could be the reasons for knee flexion. Coming to the second problem, which we have seen on the video, that there is an ankle plantar flexion or equinus at the ankle. That could be because of the short calf muscles, either gastroc or gastroc and soleus both. Or like we saw in the knee, it could be because of the long quadriceps. Similarly, the long tibialis anterior also does not allow the ankle to dorsiflex, and that could be the second reason. Similarly, like knee fixed flexion deformity, there may be a fixed deformity, plantar flexion deformity at the ankle joint. That is a third possibility. The third abnormality was in the list was a waddling gait. The child was lurching on sides while walking. And this could be because of abductor weakness, what we call it Trendelenburg gait. So for many years, we used to ask patients to undergo abductor muscle strengthening. However, they were not improving. So of late, we have realized that this waddling in cerebral palsy is not only because of the abductor weakness, but it is also because of inadequate balance of the child. We know that many of cerebral palsy children have problem with balance, and when they don't have an adequate balance capacity, they waddle like this. So now we have the gait abnormality, what could be the possibility, and now we try to correlate whether the clinical examination findings, are they matching with the gait abnormality? So now I am sharing you the clinical examination findings. So what we saw in the knee, we carry out a test which is for the hamstring length, that is called the popliteal angle. This popliteal angle was 60 degrees on both the sides. Normally, we are able to extend up to 45 degrees. That's a normal popliteal angle. Here, the popliteal angle is more, which is suggestive of the short hamstrings. There is no extension leg, means the quadriceps is not long. There is no fixed flexion deformity at the knee joint. So that basically says that the knee flexion is because of the short hamstrings. Coming to the ankle, the examination, when we carry out ankle dorsiflexion with knee flexion, means we are relaxing the gastroc, the ankle can dorsiflex up to 20 degrees. However, when we extend the knee joint, the ankle dorsiflexion is only up to 10 degrees of plantar flexion. It cannot go even to neutral position. And with knee flexion, the full active dorsiflexion is possible. So tibialis anterior is also not long, and the full dorsiflexion is possible. So there is no plantar flexion contracture at the ankle joint. So there is no ankle fixed flexion deformity or the fixed plantar flexion deformity. Imaging wise, the X-ray of pelvis with both hips is normal. So there is no problem, lever arm problem at the hips. So now the reasons for gait abnormalities. There are short hamstrings, that is a first reason. And the second is there is a short gastrocnemius. Based on the clinical examination, we could find out that these are the problems. Coming to the surgical prescription, for the short hamstrings, we need to carry out hamstring lengthening. And for the short gastrocnemius, we need to carry out a selective lengthening of the gastrocnemius. Means we lengthen only the gastroc, we don't do anything to the soleus, which is not. When it comes to hamstring lengthening, as we discussed, that there are various or difference of opinion. So some people do it both medial and lateral hamstrings, means they release 3 medial and the bicep femoris, which is a lateral hamstrings. All the 4 hamstrings are lengthened. Some people, they say that we need to carry out only medial hamstrings and we don't need to carry out lateral hamstrings. Otherwise, that will lead to recurvatum at the knee joint. And some people, they only recommend a semi-T, means semi-tendinosus transfer. Nothing to the gracilis, nothing to the semi-membranosus. So the first is the highest dose, the second one is intermediate, and third is a very conservative dosage. So this is something like if I have to give non-steroidal anti-inflammatory medicine to a patient, some people may use it the full therapeutic dose. Some people use it 75% of the dose, while some people give it a very less dose. They either reduce the dosage, means the milligram they want to give, or they increase the frequency. In hamstrings also, we have a different dose for hamstring surgery. So now this is the patient, the post-op gait. This is after hamstring lengthening, means only medial hamstring lengthening and selective lengthening of the gastrocnemius, which is called a Steyer's procedure. I am showing you the pre and the post together so that you can identify that how much is the improvement in the gait. So coming to the next, now we have a pre-op video with us and we have a post-op video. It's time to analyze that what went wrong what went well. So my understanding is, after looking at both the videos, that knee and the ankle parameters or the kinematics improved with surgery. However, the waddling persists. Gait definitely improved in efficiency as well as in appearance, but it did not become normal. So what did I learn from that? Because learning from our own cases is called the experience. So from this case, I gathered the experience that waddling does not improve with surgery. So with this, now I tell the patient that your child has a waddling gait and don't expect it to improve with surgery. The second learning is surgery cannot make gait normal. It improves, but it does not make it normal. Because many patients ask us, sir, 100% all right, ho jayega nahi? So we need to say that, yes, the child will definitely improve, but will not become normal. So the take-home message is the decision-making in cerebral palsy is very important because they have a very narrow safety margin. We need to follow a stepwise approach, which we discussed in the session. Decision making is a process which can be learned by everyone. It's not like that only few gifted people are able to make good decision. If you follow the process which I described in a step-by-step manner, yes, you can also make a good decision. With experience, my time for reaching to the decision making may be only 5 or 7 minutes. In your case, those who are beginning, it may be 20, 30, 40 minutes. In the beginning of my practice, I used to spend 1 hour, 2 hours after watching each gait cycle. Now it has been reduced drastically because of the experience. The post-operative analysis is very important. Don't just operate, but analyze your result after few months, and that gives the maximum benefit. And that provided important learning to us, which we saw in this case, and this helps us in building the experience. So with that, I would like to stop sharing and I will be happy to answer your questions. Thank you.
Thank you, Dhiren. That was excellent as usual. I don't need to add more to that. I think the steps and the thing, planning and how you execute your planning is something which should be a lesson to all of us. And I hope the residents really take something from this talk, because it actually is amazing how you step by step can work out firstly the problem and then what you can do to improve it. So that was great. Thank you very much.
So this is very important. Just I would like to add that the postgraduate students, that this will not be described in the book.
Exactly.
So please try to listen to this lecture, follow step by step. At any point, if you have a problem, just ask your colleagues, the senior colleague, or you can send your videos also.
Yeah. Great. Thanks, Dhiren. I'm sure there should be some questions, or is it so well explained that you don't have any questions?
So while we are waiting for questions, so usually in Viva, they used to ask 2 or 3 common questions. One is that about the birthday surgery, that one for cerebral palsy.
What surgery?
And birthday surgery, sir, means usually.
Okay.
Fine. Okay. Let's. I have few slides. Shall I describe that concept, because that's a very important concept? So let me take open the presentation again, and then we will come to back. Yeah, can you see the slides?
Not
no, you have to share your screen again.
Share again. Yeah, let me do it again. Yeah, sorry. Just a minute. I will open because of the time restrictions, I have. It says that. Just a minute. Sorry for that.
No, don't worry. It's not a problem. We still have about 15 minutes or. So is your presentation open?
Yeah, I have closed the presentation. That
Okay,
was a problem. So
yeah,
now I am
so-
opening it again.
Sure.
Yeah, now I
Yeah.
hope that you are able to see it, right?
Yeah, yes, we can.
Okay, so now I am going to the slide which Dr. Janki asked me. That's a very good question. Yeah, here is the Bhadani syndrome. Slideshow from the. Okay, now can you see that legendary concept?
Yeah.
Yeah, okay. So this was a concept which was described by a very senior professor at SickKid, Canada, SickKid Hospital in Canada, Mercer Rank. So according to that concept, he said that when you are new to the cerebral palsy surgery, you come across a patient who is walking with equinus. So when you look at the patient with equinus, you think that this is only the problem of calf, and you carry out a surgery, a tendo-Achilles lengthening. Nowadays, we don't carry out tendo-Achilles lengthening in such patients, we carry out striers. But in the past, the people used to carry out tendo-Achilles lengthening. And that results into a situation that after surgery, the heel starts touching the ground, but ankle goes into dorsiflexion, and there is a knee flexion. So then comes you realize that there is a knee flexion. So now you carry out a surgery at the hamstrings. So after that surgery, the ankle is in neutral position. Knee is also now extended, but the contracture at the hip, that's a psoas, is now very evident, and child is leaning forward. So now you realize that we need to carry out a surgery at the hip level. So now you operate at the psoas. So what happened that you operated a child first, so he was in the hospital. The second vacation, the child came for the hamstring surgery. You realize in the post-op video that now there is a problem at the hip. So the third vacation, you called the child at psoas for the hip flexors, and then you carry out psoas surgery. So yes, the child gradually from first to second to third to fourth position. So this is what the situation. So he called this a diving child syndrome. That is a first name. And the second name, he gave it a Bhadani syndrome. So child is spending all the vacations in the hospital. So many children whose birthday is during that period, that birthday is also celebrated in the hospital. So it's called the Bhadani syndrome. Remember, this was before 30 years where we used to keep children in the hospital for long period. But the point he was trying to say that don't go for a stage-wise surgery, identify all the problem at a time and tackle them together. So the important thing is like identify all the problems and tackle all of them at the same time. So the concept which came was a single event multi-level surgery. That was the concept that identify all the things. As we saw in the example, we identified the problem at the knee, we identified the problem at the ankle, and managed them in a single sitting. However, people started taking it in a different direction, and they say that the child with cerebral palsy requires surgery only once. That is not what we mean by single event surgery. What we understand is like whenever we carry out surgery, the surgery, all the problems should be identified. That's what we want to say. So I will stop sharing now. So that's about the Bhadani syndrome. I think it's clear.
Yeah, that's great.
So there are a couple of questions in the chat.
Yeah.
Regarding one is how do you decide the best time for surgical intervention? And there's another one on the degrees of surgery. Papers give differing opinions of the best results in their hands.
Okay.
These
Yes.
both are from Dr. Anil Agarwal.
Okay, good question. So again, like the few slides I have not covered, and that was about the timing of surgery. My current philosophy is most of the diplegic, they required surgery 2 times in their lifetime. The first between 6 to 8, where we carry out soft tissues. So what I describe in this case, we need to carry out surgery at the hamstrings level and surgery at the calf. That is usually we need at 6 to 8. Most of these diplegic children, when they are adolescent, means when they are 12 to 16 years old, they need second set of surgery. So that is basically mostly a bony procedures. We carry out a foot stabilization procedure at the foot. They may develop fixed flexion deformity, and for that we need to carry out distal femur extension osteotomy, something like a bony procedure between 12 to 16 years of age. So that is what my idea about the ideal age for surgery.
Yeah, so I think the general teaching has moved like to not to operate till the child is about 6-7 years old.
Yeah, that's very true, because they are developing their gait like a normal child. So when they are actually developing their gait, learning their gait, it's better that we don't intervene with surgical treatment.
Yeah, unfortunately, we still see children who've had TA lengthenings at the age of 2, 3, 4, and that is something which you must avoid. There
Yes.
are procedures which you can sort of at least tide them over that period if they have a lot of equinus, things like casting or even Botox, which you don't want to repeat again and again, but you can still give it once without any major issues.
Yes, that's very true. But unfortunately, many of the children in our country, not many, but a few of them, particularly those who are in a remote area and those who are not having access to the good physiotherapy, many of them are developed contracture at very early age.
True.
And we have to operate them early, but that's not the good thing. The best thing is like to delay surgery till the normal maturation of the gait pattern takes place, that is by 6 to 7 years.
Yeah, I mean, if they have extensive contractures which are which do not correct even on under anesthesia, then you are sometimes left with little choice, but you want to try and delay it as much as possible with physiotherapy, exercises, etc., casting, bracing, etc.
So one thing, sir, in your lecture, you have mentioned what when not to do surgery, although in the discussion, most of the thing is covered. If you want to add on something.
Yes, yeah, I want to add on that. When not to operate, the most important thing is like cerebral palsy children. Some of them have a dystonia. Dystonia is like the tone which is changing. The spastic means they have a tone all the time higher side. So usually in dystonic, we should not operate. So that's the first important thing, because they have a changing tone. And in that case, if you carry out a lengthening procedure, there is possibility that they may go in the other direction. So dystonia is one thing when not to operate.
Changing tone means we will call the child again and again to examine to know.
Yes. Yeah, usually like see when dystonic children, they don't get contracture. And if you are not sure, if you are not able to pick up how I identify dystonia, the best thing is to keep the child in the examination table for few seconds and look at the hand and look at the foot. You will see that the hand, they are moving like this all the time. So even when they are relaxed, they are moving like this. So this is dystonia. And if you look at the foot or the feet, you will see that they are moving the ankle into dorsiflexion, then in plantar flexion, inversion, eversion. Even if they are relaxed, this movement is taking place. So that's the thing which is really not spasticity. There is no contracture. If you are not sure, just examine them under anesthesia. And when you examine them under anesthesia, there will be no contracture of the muscle. And as we saw that the most important thing we do in cerebral palsy is when there is a contracture, we lengthen the muscle. So dystonia is one thing we should not carry out surgery.
Yeah. And other thing is when they're athetotic children, you
Yeah,
have to be really careful about that.
exactly.
One
Few,
last
I mean, they're
question.
not very common, but when you get them, you have to be really careful.
So, like most of the difficult part which you feel is like counseling the parent before the treatment. So, any tips how to tackle,
Oh,
because
that's
that
a very important question. And what I do, I will suggest. I have prepared a video of 14 children, pre and post. So any patient coming to me after examination, I feel that, yes, this child will be benefited by orthopedic surgery. I just request them to see the video. It's a pre and the post, and the pre and the post combined, as we saw in this lecture. So there are 14 children covering different type of gait pattern. So with that, they will understand two important things. Yes, there is an improvement with surgery. And the second thing, even after surgery, the child does not become normal. So that is an important thing which I always like to tell to the family, that after orthopedic surgery, we are not going to do any miracle that child will become normal. So I use uh, the pre and the post video extensively to counsel my um, patients. Previously, I used to give them the address of another patient, but now I use these videos, and that's a very effective way of convincing them.
Yeah, and I think it's really important to drive that home, that in spite of everything, the child is not going to walk completely normally, because a lot of parents have that thing in mind that they expect, especially if you're doing surgery, that the child will become normal. You are only improving certain problems that they have, and this has to be really very clearly explained to them right in the beginning.
So you have mentioned few other things other than gaits, like scoliosis and dysplastic hip. These things, like what we used to do, the treatment, what normal treatment are getting for those things, that is different in cerebral palsy, or is that same, sir?
Yeah, see, usually the hip problem, scoliosis, somehow I have seen that it's more common in severely affected children. That's called gross motor function classification level 4 and 5, which is mainly very little ambulatory capacity.
Bedridden, yeah.
Yeah, bedridden or something like that. They are prone to get scoliosis. The sad part of our country is that most of these children, they don't reach to the orthopedic surgeon because they are neglected, which is sad part for our country. But if you look at any other Western country where the medical treatment is free, their major burden is managing the scoliosis and managing the hip problem. The same thing in India also, the hip problem, unless and until it is really a problematic to a child in the form of pain, very few parents, they come for the management of this problem. And many times when we explain that child requires surgery, they say that it's not causing any problem to a child, or this child is anyway not going to walk, then what is the benefit of doing hip surgery? So that's a very different scenario in India. If you go to any other developed countries, most of the cerebral palsy surgeons, they are doing 50 to 60% of their work is managing the hip dysplasia.
Yeah, so the hip also you need to watch very carefully, because the hips could be normal initially, and then if they have a severe valgus or a lot of adduction, then it gradually drifts into sort of subluxation, etc. So that you need to catch them in the right time if you want to do something. Okay, once they're dislocated, then it becomes very difficult to do anything. Yeah.
See, Pediatric Orthopaedic Society of India, POSI, has developed a very good surveillance guidelines for hip problem in cerebral palsy, because the prevention is better than cure, which is very aptly applicable to this problem. So we want to identify this condition as early as possible and deal with a very small dose of surgery like a soft tissue surgery. But it's a difficult task because the number of children, particularly those who are not in the metros or the
Don't
major
ever get to.
cities, to bring them to the physiotherapist or any orthopedic surgeons for the hip surveillance is a big challenge.
And the scoliosis problem is usually in non-ambulatory children. Okay, so they are either wheelchair bound or bedridden, and it require very major surgery and often quite extensive fusions. So they really need to be dealt with by specialist units who can deal with it. So I think this is going to be maybe in the next few years in the metros, you'll start seeing some of these problems, which we don't actually see very often, because usually the child that child who's that bad never even gets to a proper medical treatment. Well, some of them
That guideline will.
So some of them don't even survive, I guess. So depending on where they are.
So that guideline will be available on the site of.
It's available on the POSI website. It's freely downloadable, and it's very simple, written in a very simple language. So any postgraduate or any orthopedic surgeon can understand what we want to do or what we want to achieve.
Okay, great. Thank you very much, Dhiren. I think all good things must come to an end. So it's 8 o'clock. So I think we need to close down for today. And it's really been useful. And we look forward to further interactions or talks with you in the future.
Yes, sure, definitely.
Sure, that's great.
Thank you.
Thank you very much, sir. It was great.
Yeah, bye.
Sure. Bye, everybody. Thanks.
Thanks.